What's up, everybody? My name's Garrett. Over the course of the past couple of years, there's been increasing concern with autism and the options for care and treatment. Today, I'm interviewing Dr. Burton to discuss what autism is, how it works, and how TMS might be an effective way of improving symptomology. Dr. Burton, how are you?
Good. How are you?
I am good. I am so excited for this podcast. Let's start really quick with just an introduction into who you are and what you do.
Okay. Well, I'm Dr. Burton. I'm a psychiatrist. I actually am primarily an adult psychiatrist. I've been here at Redemption Psychiatry since 2015. And it was about that time that we started doing advanced treatments. Advanced treatments meaning specifically TMS and ketamine, but we are also involved in VNS, vagal nerve stimulation, and deep brain stimulation. So Dr. Friday and I kind of I take the VNS, he does the DBS. But yeah, so my background actually is in chemical engineering, and I worked as a propellant engineer before I went to medical school. Mm-hmm. Did a little bit of ophthalmology research, so I've been kind of all over the place. But I think with that background, it's been really valuable for me to be able to apply certain engineering principles to psychiatry. Mm-hmm. And you know, I'm actually thankful for that because in particular, there is definitely some engineering involved in Transcranial Magnetic Stimulation, TMS.
Right.
So, yeah.
I have a quick question about that, actually.
Mm-hmm.
So, when engineers solve problems, there's a lot of value to solving it the most cost-efficient way possible, right? And troubleshooting the most cost-efficient way possible. Is there like a mode of operations you use, or are there principles in engineering that you learned that you apply to mental health in order to have the best sort of ratio of likelihood of success versus cost when you're treating patients? Does that make sense?
Yeah, I mean, I don't know if I've ever applied that specifically, but, you know, one of the things that, and this is a little bit of confession here, but I approached medical school with an engineering approach. Mm-hmm. And so in engineering, we would have open book tests all the time because the type of testing, they're trying to test us on principles. Do we understand the concept? And so they would, you know, we have charts and tables and, you know, we have access to all those in solving these problems. So it was really kind of a principle driven problem solving. So I thought, yeah, I'm going to use this approach in medical school. And there's some things in medical school like pharmacology you just have to memorize, and it killed me because I was trying to like find patterns to pharmacology, you know, the different names, like, oh, the ILS, that's an ACE inhibitor, and if it ends in all, that's a beta blocker. It didn't work completely in my favor, though. So anyway, but I think that because a lot of medical school is memorization driven, I think there can be a tendency for doctors to try to apply memorized principles instead of a problem-driven approach, right? And so in terms of, and that's something that I think is maybe different than my approach than some other doctors, is that my tendency is more to think about things in problem solving instead of just like, okay, well, what can I remember, you know, these 5 things, and then I apply it to the situation. Does that square fit in this
in the whole situation?
Yeah. I was like, oh, well, it doesn't quite fit. Well, we'll try and make it fit. It makes it a little bit harder, I think, to apply some principles. So anyway, I that's something that I think is I'm thankful for that background in engineering, even though
that's so interesting.
It gave me a struggle in medical school. Yeah.
Okay, so let's just dive right into autism. Okay. This thing I'm really excited to talk to you about today. I have a very cursory understanding, so I'm hoping that you'll be able to correct me and explain in a lot more detail. Let's start with autism in the brain. So there's been a lot of publicity, especially recently, in regards to causation of autism. It seems like there's been a lot of research around genetic culprits, and it hasn't turned up a whole lot. But you can correct me if I'm wrong on that. So help me understand, what is autism? Where does it come from?
It's been figured out.
Okay.
It's Tylenol. So.
Okay. Done?
We're done.
Okay.
No, it's unfortunately that commentary is I think most people in the medical community just kind of like, oh my gosh, right. Because we know that autism is actually very complicated, and in terms of the genetics of it, it seems, and even if you look at people who have autism, the penetrance or the intensity or the degree of symptoms that people have varies intensely, and even the type of symptoms that people experience and how they manifest is very broad, and so that by definition seems to imply that there's going to be multiple causations. And when we talk about penetrance genetically essentially means that there's a greater degree of illness. And so the greater the penetrance, the more significant the symptoms, right? Mm-hmm. So what can explain that? Well, one of the things that would make sense, and there, I've heard at one point that there's maybe 20 genes that contribute to autism spectrum. So if you have 3 of those genes, you might be quirky, mm-hmm. but you don't really actually have autism spectrum, right? You don't even meet criteria for it, but you might be quirky.
Right.
And so I don't know that anyone's ever defined, I'm just like throwing these numbers out of the air, right? But the principle might be like, if you have these certain genes, then if you have 8 or more, then you have autism. But if you have this one, then you have 5 or more. And so it's, again, the diagnostic or the application of the just genetic theory is going to be very complicated in and of itself, right? Mm-hmm. Now, there's probably also environmental factors. And so that further complicates the presentation, right? And environmental factors could be exposures to certain medications or certain things in our environment. Is it possible that there's also behavioral exposures where kids don't get certain interactions? Can that contribute? Maybe. I mean, some of these things we just don't really know. We suspect, and there's been a lot of studies. Like one of the big studies that it has actually been studied multiple times is, can you actually improve symptoms by giving fish oil?
Like omega-3s?
Mm-hmm.
Okay.
Yeah, and that hasn't really panned out significantly. But despite that, there's a drug company that actually developed a medical food mm-hmm. that has a very, refined and specific ratio of DHA and EPA, fish oils, omega-3s, that is supposed to improve some symptoms. So it's, again, it's just very complicated, mm-hmm. and which creates 2 problems. One is that's the background out of it, right? Like where does it come from? How do we even prevent it if we don't even know exactly what's causing it? Right. So it becomes there's a lot of challenges with it. Yeah.
Yeah, it's really interesting. One of the things that struck me was, like, my dad always says there's 3 types of lies. There's lies, there's damn lies, and there's statistics. Mm-hmm. And it seemed very true with autism causation, because people would be like actually, to give an example, so outside of autism, about a decade ago, the British government was talking about geriatric pregnancy, so pregnancy over, I think it was like 35, mm-hmm. And said this doubles the rate of severe mental defect in children. Mm-hmm. Doubles. So everyone's thinking, oh my God, it doubles the rate. Well, it doubles the rate from like 0.4% to 0.8%. Mm-hmm. So you're still under 1%. So depending on how you phrase it, right, you can elicit these really strong reactions. And I think that makes it really hard, especially for like parents of kids who have autism, to figure out like, okay, well, like most moms and dads aren't adapted to go look through the actual literature and see what the percentage increases were. And so,
well, and even to that point, in terms of like, is maternal age a risk in developing autism? Yes, it is. I actually happen to know a family who I think they have 6 children, and their second oldest has autism spectrum. None of the other children have it. So maternal risk doesn't seem to play a factor in that family.
Right. Huh. So let's backtrack a little bit then. What is autism? Like if I had a psychologically normative brain and or a neurotypical brain, and I had a brain that was we'll say had a lot of autistic symptoms, right? We'll say it was a more severe case. What changes would I see? What would be the differences?
One of the most sentinel things that we see in autism spectrum is delayed speech. And so that's something that is typically seen starting around the age of 1 when people start to develop speech. So that's a key part. A second part is interaction socially, and usually that's impaired in some way. So there, you may see these kids that are, and there's something called parallel play, where 2 kids may be playing next to each other, but they're not interacting. That's a pretty normal part of development around the age of 1, 2. 3 years old, kids start to interact a little bit more. And so someone on the autism spectrum may not start to develop that, right? Or they may be more delayed in even noticing that there's someone next to them in playing, right? So they're not going to they're going to continue on with that parallel play. So there's kind of this delay in even being able to interact with other people. And some other features that we also see with autism spectrum are, difficulty adjusting to changes. And so you sometimes see these kids who are just very rigid. They're very sensitive to stimuli. And so they're, difficulty in transitioning, going from like home to a different environment, just like it's time to get into the car, and they just freak out and like, what is wrong? We're just going to the car. But they have this system of how they need things to be. It's easier for them to deal with the change by having things very predictable. And so it's difficulty with transitioning, and again, sensitivity to stimuli. A lot of times you can see stereotypies as well, and a stereotypy is behaviors where like there's the rocking,
right, like
and some of these things are like pressure that can help self-soothe. So a lot of times these kids kind of figure out just naturally that certain movements help them feel better, help them feel more grounded. Interestingly, though, because of the social issues, it's, and this is kind of an interesting thing, to kind of tricky, but a lot of times these kids, they like certain types of touch, but not typically the touch that we would see as reassuring. So like a hand on the shoulder, or a gentle hug, or, nice, soft back rub, don't like that a lot of times, right? But they might like some like firm, like a firm just like holding them, or, putting pressure on their head. Those are things that, so that even like the way they interact with people with touch can be changed.
That's really interesting. In terms of Well, so I've got a lot of questions.
Okay.
Do we know why that is? And I know, like, we've already discussed about autism, the symptoms are so wide. And, like, I had Nathan Palmer, who runs a school for autistic kids, on a couple weeks ago. And he was like, if you've met one person on the spectrum, you've met one person on the spectrum.
Yes, I love that.
Yeah, which is really great. So a couple questions is there continuity neurologically in patients with autism or not? And what are treatment options like if the disorder is so diverse?
Right. That's something that I think is still under investigation. One of the things that actually we're looking at right now and working with a company is it's a company that has several imaging devices and other devices that integrate with TMS, but in particular, this device, the functional near infrared scanning device, it's a way of looking at functional imaging of the brain. And one of the things that they're looking at is there a certain type of pattern that we see more consistently? And they have started to see kind of a range of brain functioning that seems to be more consistent with autism spectrum. So that's something that can be helpful. Of course, you always, whenever you have a test like this, with something that's so complicated, as I alluded to earlier, you're always going to have false positives and false negatives, right?
Right.
But, the hope is that we can capture, we can start to have ways to even just image and be able to use that diagnostically. I mean, really the gold standard right now of diagnosing autism spectrum is a clinician-led interview of someone who really knows the criteria well. But a lot of times that in combination with that, it's, interviews with not only the person, the patient, but also with their family, and maybe, screeners that are filled out by a teacher, where different aspects of their life can be evaluated and kind of combined into one full assessment. So that's our best way of like actually diagnosing it. But it's not. I would argue that that's still kind of clumsy because there's some challenges with that. If you have a clinician who's not very well trained, they may not be as good at discerning, and applying, like, are these people that actually have the right criteria or not? Right. And we see nowadays there are probably a lot of people that are actually being misdiagnosed with autism spectrum. You get parents who look up the symptoms online. They really want to help their kid. Their kid's quirky, probably not on the autism spectrum, but they say the right things to the clinician, and the clinician's like, sounds like autism. And then on top of this, we get even more misinformation with social media, where there are things that can be associated with autism that are then taken to be actually diagnostic criteria. They're not, but they're taken to be diagnostic criteria. And now you have like, oh my gosh, I saw this TikTok video, and like my kid, yes. I have autism. I never knew this, right?
Right.
And one of the things that will happen though is, and it becomes challenging, is like, people want to have a diagnosis that helps explain some of their challenges. And so it's understandable that people will go there. Unfortunately, what ends up happening though is then you have people diagnosed who actually don't meet criteria.
Right.
And then the services for the people who actually need them, it becomes more limited for those people. So this gets into your next question though, is what are treatments for autism spectrum? There's not a lot. We know that, and there's some studies done on ABA therapy.
Yes.
Where ABA therapy, I'm trying to remember what it stands for. I don't remember what it stands for, honestly.
Yeah, it's okay.
But it's essentially, it was studied in a very narrow area looking at specific criteria. And it wasn't intended, even by the original author, to treat all aspects of autism spectrum. I believe it was only intended to treat, and I'm probably going to misspeak here as well, because I don't study this stuff as much, but more of the behavioral interactions, like being able to cope with changes, right?
Mm-hmm.
But it doesn't improve social interactions, and it doesn't improve language, as far as I understand. So there's some things that it just is limited in doing. Now, some people extrapolate like, oh, well, we do this therapy and we interact with the kid and it is working. Like, okay, well, is that ABA actually treating autism spectrum though? Or is it you work with any kid for 3 hours a week that's 5 years old and is learning to develop language? They're developing their language. And are they going to develop language? Absolutely.
Right.
They will. So this is, again, where there's been some challenges. There's really not any medication that is also intended to treat autism spectrum. Now medications are used, and the way it works and the way it can help is a lot of times kids and people with autism spectrum can have comorbidities. So there's a fairly high comorbid rate. I believe it's like 20 to 30% of autism spectrum with ADHD. So you give someone who is on the autism spectrum and they have ADHD, you give them a stimulant medication or some kind of medication that helps them with their focus or distraction, and they'll do better and they'll transition more easily. So does that help the autism spectrum? For sure, it does. But it's more of an indirect treatment, right? So we're more treating some symptoms that can come from autism spectrum.
Right. That's interesting. It's sort of like in terms of IQ, right? Intelligence and increasing intelligence. There's plenty of companies that will be like, oh, our games, right, will increase your intelligence, right? If you play our games, you'll learn more. And it doesn't really seem to be the case. It seems like if you do crosswords, for example, your whole life, when you're 80, you won't be doing much better than you would have. You're just going to be really good at crossword puzzles now. And so it's like a siloed skill. Generalization of skills and nuances seems to be one of the big issues, right? It's like you can teach someone how to do something, but to help them generalize that into larger life skills can be tricky. Is that right?
Yeah, and I'll play devil's advocate a little bit on the crossword
Sure,
puzzles.
that's great,
right?
yeah. Do you like crossword puzzles?
Well, it's not that I'm defending that, right? But there are some studies that seem to suggest that as people get older and in aging, that doing things like Sudoku and crossword puzzles can be protective against dementia. Now it's protective, right? It's not,
right.
That doesn't mean preventative, but protective. So, I mean, there are some things that can be helpful in protecting our brains, right? I think sometimes the promises are extrapolated a little bit too far.
You become a genius. Yeah.
Like, oh my gosh, I did crosswords. How am I developing dementia? Like, that's like, they lied to me. Like, well, it wasn't actually a lie. It was probably like a little bit misrepresented, but yeah.
So I'd like to backtrack a little bit. You talked about seeing a professional to get diagnosed for autism. And usually that seems to be done by psychologists. So I think it'd be really great if you explained the difference between what a psychologist would do and what a psychiatrist does. That's probably the most common question we get. Yeah. And especially as it relates to our topic today.
For sure. Well, and as a psychiatrist, I have been called a psychologist
your whole life,
probably as many times as I've been called a psychiatrist. So,
yeah.
So The education of a psychologist, let's first talk about that, and then let's talk a little bit about how they're different. But a psychologist has a different track, right? So in terms of their education, they'll get usually a bachelor's degree, maybe they'll get a master's in between, but then, a lot of times, the higher level psychologists are going to get a doctorate. And a lot of their focus is going to be, a lot of doctorates in psychology will be clinical, so it'll be clinical psychology.
Mm-hmm.
But a lot of times what they're doing is either they're focusing more on therapies, specific therapies. And so psychologists, I would argue, like a really good psychologist is going to be way better therapist than I am.
Mm-hmm.
But they will also a lot of times have experience in evaluations. And so they do a lot of studies or a lot of work in learning how to administer tests and how to, combine these together into a psychological evaluation, right? So they do a lot of work there. As a psychiatrist, we learn how to recognize these studies and how to recognize, the tests that are done, like the MSPE and the MSE, and there's a whole battery of tests that can be done looking at personality disorders, symptomatology, some that are more focused on specific areas of learning. There's also tests that are done that are looking at like spatial reasoning. So there's different aspects of the brain that they're trying to assess, right? Just a quick interesting side note. Most people have heard of the Rorschach test,
yes,
right? Which is the ink blot test, right? And interestingly, that itself, in order to be qualified to administer and interpret Rorschach, you have to have specific training for a year just to do that. And interestingly, also, don't look them up on the internet, and everybody will. But they're actually specific. There are 10 specific ink blots that have been validated, and so they've validated them over thousands of patients. But the utility of them really depends on not having seen them before,
right?
So that you can't like pre-think about what you think you see there. So, but even like how people answer, it's a very complicated thing. It's actually one of the very few. I think they call it an expressive test. Most tests are more on the side of being kind of almost this more objective.
Right. They're constrained to try to.
Objective instruments where you just like add up numbers, right, depending on how they responded. So that's psychologist, right? A psychiatrist, we go the track of going to, bachelor's, then going to medical school. And then in medical school, we'll do 2 years of rotations, our third and fourth year, where we're exploring everything. So OB-GYN, gynecologist, surgery, internal medicine, psychiatry, but then also other things like, other options like radiology, pathology, ophthalmology. I did ophthalmology. I was going to be an ophthalmologist. Yeah. So we explore all these fields of medicine, and then we'll go to another set of training that can be typically from 3 to 5 years of residency specialization. And so that's where I became a psychiatrist, general psychiatrist, 4 years of specialization after medical school. Dr. Friday did 5 years, and so his last 2 years were actually child psychiatry, right? So he's more focused on, has more training on things like autism spectrum, right?
Right.
So that's, and the other thing that is different is psychiatrists prescribe medicine. Typically, psychologists don't. Now, there are a couple of states actually where they have some limiting prescribing privileges. And in multiple states, actually, there has been a push for psychologists to write medication. So I'll go off on a little tangent here this is kind of an interesting tangent. But here in Arizona, there's been, every time it's been brought up, there's been enough opposition to this to shut it down. One of the biggest concerns with this is if you just look purely at the numbers, how many hours of medical education in prescribing do 3 groups have? Psychologists, on average, have 32 hours of medical training in prescribing medications. Nurse practitioners, about 600 hours. Medical doctors, about 1,200 hours. So who would you want prescribing you medication?
Yeah.
And the concern is this. We look at some things like serotonin, reuptake inhibitors. Like, that's Prozac, pretty benign medication, which is true.
Mm-hmm.
Are you overlooking anything medical, though? Do you have the medical training to understand what kind of interactions could be happening if you have 32 hours of medical training? So that's where the big push has been like, no, psychologists have an area of expertise that is way beyond mine, that I would never venture to do assessments. They just know that stuff. I don't. But that's the main differences between the two. Yeah.
That's great. So going back now to autism treatment and advanced treatments in general, we got to get to TMS. Yes. Right? This is so important. So for reference, when I got a bachelor's in psych and then I got a master's in work psychology, IO psychology. And I went through 6 years of school, and I maybe read one sentence about TMS, right? And admittedly, I wasn't going a psychiatrist route or into medical school, but it's really, in my opinion, criminal, which is why I love what I do, just spreading information about it, because there's so many people who, if they knew that it was an option, they would pursue it, and especially because it's not another medication. Right. And so it's been approved and shown to be valid for depression. But let's talk about that and how it works, but also what Redemption Psychiatry has been doing with TMS and autism.
Yeah. Yeah. So it's
sorry, I know that was like 12 questions.
Yeah. Well, let's back up on the history of TMS. When I was in residency, I remember in 2009, the main training I got on TMS was a doctor in Scottsdale came and talked to us about it. And she's not super, she's like, yeah, this is kind of an interesting treatment. And I do maybe like 2 a week and at most, or maybe 2 a month, two patients a month. She didn't really think that it was super effective, but she's like, I guess it's something you can try. That was kind of our exposure in 2009. Now, to be fair, at that time, it was not even covered by insurance. And so anybody who's doing it was cash pay. It's pretty expensive. You're looking at $12,000, $15,000 for treatment. So not very accessible to most people. After 2013, when you started having insurance companies cover it, it started to gain some traction because there were more people who could do it. And that could be part of the reason that there were, like, especially when I was in school and when I heard nothing about TMS, but, TMS was discovered in 1985, but wasn't really, I think it was FDA approved to treat depression in 2007, 2008, around there. So it was kind of just right around that, it was after I was out of medical school. So like, why would they be talking about this experimental treatment at that time, right? So, but yeah, in terms of what does it treat? TMS currently has 3 FDA approvals for depression, major depression, smoking cessation, and OCD. Those are the only 3 right now that is FDA approved. So when we talk about TMS for autism spectrum, at this point, it's not FDA approved yet. There are a lot of studies being done, though, looking at other applications of TMS, all the way from recovery from stroke, improving symptoms after a traumatic brain injury. We've even had some success in treating people with tinnitus, so that ringing in the ears, with voices, auditory hallucinations, with depression, obviously, but also with the associated anxiety. There's some improvement in PTSD. So I'm kind of going from more obscure treatments to some of the more common ones. So I'm going backwards. But in terms of autism spectrum, TMS is really exciting because it's something that can promote change directly on the brain that is problematic. Now, I failed to mention when we were talking, I guess I couldn't quite get there,
You're good,
what causes autism. The cause is different, I would say, than what we also see in the brain. And so one of the things that we see in a brain with autism is, and what has been described, and I don't remember the physician who's done a lot of the work in this, but he's done a lot of work with autism and TMS, and what he has described is there's something called migration of inhibitory neurons. So let me back up here and let's talk a little bit about brain development so that even makes sense, right?
Yes.
So as our brain develops, it kind of develops. I better keep on speaking in the microphone, right? Turn to the side.
You're good.
But our brain, I'll just turn to the side for a second here. Our brain grows from the midstem or the brainstem and forward, right? And so it has this forward development. As we go from midbrain structures to the limbic system and to the frontal lobe and to the prefrontal lobe, those structures become increasingly advanced. There's this idea that our development, the development of a fetus as a person grows, follows evolution.
Yes.
Right.
Okay,
So when you think of midbrain structures, that is just purely heart pumping, lungs breathing. Right. That's it. And then you get to, and so if you have just limbic structures, you're talking like lizard brain, right? No emotion. Now you get to limbic system. Now you have mammals, and now you're talking about limbic system, emotions. Mama bear sees Garrett,
fight or flight,
and even though he's 160 pounds, and her cub is 300 pounds, she's like, he's gonna kill my baby, and I'm gonna kill him.
Right.
Like it's all instinct, very emotion driven, no logic to it. Then you get to a frontal lobe. Now you start to have, and of course a bear has a frontal lobe, but not a very large prefrontal cortex. So the more advanced creatures become, the more of a prefrontal lobe we have, right? So this is where we call this migration. That's the migration as the brain develops. And we have two types of neurons that balance each other out. There's excitatory neurons and inhibitory neurons. And these are always, and this is where my chemical engineering comes in, right? Yeah. These are always balancing each other out. So when you have a thermostat and you have it set, it's going to, the AC will turn on until it reaches 72 degrees. And then it'll heat up until it reaches 73, and then it triggers the system to turn on again, right? So it's this balance of, and really what you have there is you have an excitatory and inhibitory. If you want to call inhibitory lowering the temperature and excitatory increasing the temperature, right? So the environment is excitatory, the AC is inhibitory, and they balance each other out. They're constantly balancing each other, right, to maintain a certain level. So we have this going on in our brain all the time. Excitatory, I'm going to say something to Garrett. Inhibitory, I need to listen. I need to stop my brain and just listen to what he has to say. I'm not going to interrupt him.
Thanks.
That's my inhibitory in action, right? So if I have an imbalance between inhibitory and excitatory, it's going to create dysfunction. So getting back to autism spectrum, what we understand is that inhibitory neurons do not migrate as well as excitatory. So then what do we have? We have more excitatory than we have inhibitory. So now let's think back to what do we see, going back to those previous symptoms of people on the autism spectrum. Difficulty interacting with people. Okay, does that make sense? Well, that imbalance, maybe not as much. But let's talk about going to Costco. How many times have you seen a kid who has earmuffs? And they're looking at their iPad? Their parents are helping them manage overstimulation. Right? They're very sensitive to stimulation. And so the equivalent, when you have less inhibitory compared to excitatory, the equivalent is like someone who's normotypical. Like you go to Costco and you're like, it's noisy, it's chaotic, whatever, I'm going to get what I need. Versus someone that's like, turn the volume up like 20 decibels and you go to Costco, how does that feel?
Right, that'd be
You're
a
like,
nightmare.
oh my gosh, this is like a rock concert. Like, I don't want to be here. Like, Costco's not a rock concert. It's chaotic, but it's not a rock concert. But it's kind of like this.
It's
for
like
people
gain.
on the autism spectrum.
It's like gain in audio.
Yes. It's like you turn up the gain. So, and that's another great example. What happens when you turn up the gain too far?
Static.
You start to get feedback, static. I talk too loud into the mic, and it starts to just goes.
Yep.
You get that feedback, right? You're like,
yeah.
Feedback. Oh my gosh, just turn it off. Can't handle it. And this is what you see with these kids, right? They're just like, they start to vibrate, and you're like, what is wrong with you? There's not that much stimulation. And some of the stimulation can come internally, right?
Right.
So it doesn't even necessarily have to be environmental. So now let's talk about TMS. So there's not any, in terms of medications, we don't really have any medications that specifically target the excitatory neurons that are throughout the brain. We don't really have anything. I mean, we can, now sometimes we will give like antipsychotics, which are inhibitory of dopaminergic neurons. So dopamine, okay, that's one neurotransmitter. But if we're talking about excitatory neurons, we are talking about not just dopamine. We're talking about things that other people, people are maybe familiar with, like norepinephrine and serotonin and acetylcholine. But we're also talking about other neurons that we are maybe not as familiar with, like glutamate and AMPA and chironine and things that I'm like, oh yeah, I remember hearing about that in medical school.
Yeah.
There's this super complex system we have in our brains. And I would argue that we probably, of the neurotransmitters that are in our brain that could be potentially modulated, we modulate about 5 to 7 of them. So, acetylcholine or serotonin or epinephrine, dopamine. I don't have to list them all, but glutamate and GABA, but those are the main ones, right? That we're in histamine. Those are some of the main ones that we modulate. And yet that's probably 20% of the neurotransmitters that could potentially be modulated in our brain. Like we are scratching the surface in terms of medication, in terms of what could be done to modulate people's brains. Now, we've had some success with these medications. But again, okay, so I tend to go on tangents.
No, it's beautiful. It's awesome.
But let's come back again. This is the beauty of TMS. TMS, and what we know with depression is one of the things that it does is we are activating a circuit that seems to be low in activity. But as we activate that circuit, we bring blood flow to the area, which helps the brain to heal the neurons. It just, blood brings nutrients. Nutrients brings healing, right? So that in and of itself can be healing with TMS. On top of that, we know that as the brain becomes more active and healthy, it can modulate all of those neurotransmitters that we know and all of those neurotransmitters that we don't know. It starts to modulate them on its own. So I would much rather have your brain fix itself than for me to try and figure out how to fix your brain if there was something wrong, right? Because it's so complicated. I can't do that. And we don't have medications to do that. Right. So this is where TMS is really amazing, is that we are really getting to some of the core issues. So now let's talk about TMS and autism. Sorry, because you asked so many questions.
No, you're good.
And so this is kind of the coup de grace of what we were going to talk about today. What the treatment that we do for TMS, with TMS for autism spectrum, is it's a bilateral inhibitory protocol. So we target the two dorsal lateral prefrontal cortices. So these are prefrontal structures, right? These are so the most advanced part of our brain.
It's like higher decision making.
Higher decision making, our personality, our ability to inhibit things, our ability, it's highly indicated with ADHD and our ability to focus, but also with depression. These areas are also indicated in just learning. So that's part of our learning circuit. It's also part of the part of our brain that helps modulate emotion. So all of these things are targets of functions of the dorsal lateral prefrontal cortices. So, but let's just go simplify this, right? To just getting back to the poor migration of inhibitory neurons. So you have this imbalance of excitatory and inhibitory. So we do a 40-second theta burst stimulation protocol, which inhibits the prefrontal cortex. Sorry, I was just thinking about something else for a second. So it inhibits it, right? So some of the things that I think are great about this are, one, TMS in and of itself can be a treatment that, sometimes people are sitting in the chair for 18 minutes. And so you have this person, let's say a 12-year-old kid on the autism spectrum, doesn't like to be touched. And now we're going to have you sit still for 18 minutes. That'd be a nightmare a lot of people can't do this, especially on the autism spectrum.
Right.
But this protocol that we do, it's only 40 seconds on each side. So it's pretty quick. And over the course of, typically what we do is 10 treatments. So 5 days a week for 2 weeks. And in that course of time, we can create some inhibition. It helps these kids to, calm down. They're not as overstimulated. They can kind of think more logically now because there's not the feedback with the gain turned up, right? We're turning down the gain a little bit. They're able to modulate their emotions a little bit better. It's really amazing. And I'll say I've seen a few patients be treated. I actually have a patient whose child is on the autism spectrum, and she's received a couple of treatments, and she was at the point where so agitated, medication was not working, antipsychotics weren't even touching her. And we did a TMS treatment, and she was able to sleep on her own again. She's not worried that mommy is going to leave her and had to be in her sight every second of the day. It was affecting my patient's mental health because her daughter was so dysregulated. So it just was amazing. It was life-changing for my patient and for her daughter. So, but we see this with patients.
Yeah.
Hey, what's up guys? My name is Garrett, and this video was made possible by Redemption Psychiatry. We're a private practice located in Arizona focused on providing mental health services for those in need. If you or anyone else you know is struggling, please feel free to have them give us a call today. Thanks, and we'll get back to the video.
Let's talk about how TMS works to accomplish that. One of the things that makes TMS different than medication is you've got more knobs to turn, right? With medication, you basically just have, how much, right? And then you can try different medications. But TMS, you have treatment location, you have strength, and a variety of other things that can influence effectiveness. It's one of the things that probably causes TMS research to move slowly is because there's just so many options to try, and every single one demands a study to validate. So, but it's also what allows TMS to treat a variety of conditions, right? Because you can adjust it to accomplish different goals. So walk me through a little bit of the mechanics of TMS and then how that works on a brain that's depressed or has autism spectrum disorder.
Okay, well, some principles of TMS are, first, we do have, interestingly, two main types of protocols. We have excitatory and inhibitory protocols. So interestingly, this also is kind of natural in the sense of more natural in terms of how our neurons work. Our neurons, in a way, when you get down to the microscopic level, are like computers. They're zeros and ones. They're excitatory and inhibitory, right? We're turning off or turning on. And so there's a similarity with how TMS works. Typically, higher frequencies but specifically intermittent frequencies are excitatory, and then you have sustained frequencies or continuous without breaks. Those are inhibitory, right? So it's almost like fatiguing a circuit.
How does it? Let's backtrack even farther to how does it affect the brain it uses magnetism, right? Transcranial magnetic stimulation.
So let's get to the physics of this.
I'm just dragging you through everything today. It's great.
Love the physics of it.
Cool.
So some people might appreciate the right-hand rule from physics, but essentially it's a concept that says if you have a current, and those are my fingers that go in a coil, my thumb becomes the magnet, right? So when we talk about like motors, the way a motor works is it actually is using an electrical current to create a magnet, and the magnet actually spins something. And you can create a lot of torque with that. Anyway, so it's this really cool principle of a coiled circuit or coiled wires creates a magnet, and so it goes both ways though. An electric field makes a magnetic field, but a magnetic field also creates an electrical field. They are interchangeable. So we kind of do essentially with TMS, it is an electrical. So there are two main types of coils. One company has a helmet that is, they call it their main coil is the H1 for depression. Every other TMS device in the United States is a figure 8 coil. So you have these two coils that intersect, and where they intersect, you have positive interference where the two fields add up on each other. So this is kind of the main target, right? But we do so it creates a magnet. So this field, it's an electric current, creates a magnetic field that touches our brain, and when it touches the brain, it creates an electromagnetic stimulation. So it's actually, and this is why we call it transcranial magnetic stimulation, although it is an electromagnetic pulse that's created. So it's essentially it is still electricity that's activating that circuit through a magnetic field. So that's the physics of it.
Right. But unlike ECT, you're not running current through the brain. And I like the simplest way of describing the difference between ECT and TMS is they both use electrical modulation. ECT is like your computer's not working, so you just do a hard reboot. You just shut off all the power and then restart it and see if it helps and see if it works. TMS is like hiring a computer scientist. It's very targeted. It's a very specific area of the brain. So we don't have to hit the whole brain and hopefully the reset works, right? So by being that targeted, we're going to have less side effects. And specifically, the side effect that is most of concern with ECT or electroconvulsive therapy is memory loss. And so, when we do TMS, I have never seen a study where people experience memory loss. I haven't seen it, and I've had a couple patients say like, well, maybe my memory's a little bit different. It's hard to say though because they were all there were other things going on, right? So, but let's say at worst, it is a rare side effect of TMS. So, and we're talking like 1 in probably 10,000, 1 in 50,000. Like it's extremely rare. I just don't see that. And it's because we can be very targeted. We're not causing
changes in other parts of the brain that we don't want to cause change. So that's one of the great things about TMS. Now let me talk about another mechanics of TMS and how it works. And I think this is helpful too, because when we talk about, oh my gosh, you're shocking my brain. I've had patients come and say, I'm ready for my brain shock. I'm like, oh, I don't like you calling it that. But I mean, they're not completely wrong. But if you think about how does a battery work? So a battery uses a direct current, and essentially it's a tube with a membrane in the middle. And as you connect two wires across a battery to a light bulb, right, as soon as you create the circuit, you start to have migration of a chemical across the membrane. And that migration of the chemical creates a current. So it creates this stimulation, right? How do our neurons work? Well, our neurons use myelin, but it's essentially using chemicals going across different gradients to create an electrical pulse. So our brains and our neurons, our nerves, actually are like batteries. So you can actually, and this is why we use measurements of electrical activity in the body. That's why we do an EKG, electrocardiogram, an electroencephalogram. So when we're measuring the heart, when we're measuring the brain, we are actually measuring electrical activity because our bodies create electricity. So it's, in that sense, we're harnessing with TMS a very natural process that our body already uses, right? We're just trying to augment that to correct dysfunction. So we're so familiar with medication where we chemically modulate the brain to treat conditions that when we hear things like electrical modulation, if we're not as familiar with it, we're like, oh my gosh, that just seems so barbaric. And
One flew over the cuckoo's nest. Yep.
Yeah, right. And yet it's actually as natural, and in some ways I would argue it's more natural than chemicals. Because when I give someone Prozac, it has to be in their brain to keep working. And as soon as Prozac is removed and that chemical is removed from the system, that brain does not function like it does when Prozac is in the system. It's dependent on that chemical change. What's the problem with that? That chemical goes everywhere. So even though I'm targeting the brain, it goes everywhere. And so you have potential for side effects in all the body systems. Now, when we're talking about TMS, which is very targeted, there are two things that are really awesome about it. One, it's very specific. So the amount of side effects that people will experience with TMS are very minimal. The most common side effect people have is headache. And that's because you just have this tapping on your head. So that makes sense that you'd have that side effect. But otherwise, like the types of systemic side effects that people experience with medications, very minimal. Like you don't really see stuff like that with TMS. But the second thing that's amazing is once we help the brain heal itself, and I want to caveat, there are times where we have to repeat TMS, right?
Sure.
But that being said, the person is not dependent on having a response by having this chemical in their body for months, years at a time. So like, I would say the average response that we see with TMS for depression is maybe 2 to 3 years, where people still, the average is people still don't relapse to their previous state after 2 to 3 years. Now, some people do, but the point is this: 30 days of treatment for 20 minutes, right? So you could say a cumulative exposure of about 10 hours for 2 years, versus 750 days for 750 days, right? I mean, we're talking like, that's a huge difference, right? In terms of exposure.
Right.
So anyway, if you just look at that part, I think that TMS, when it works, is really amazing for people and really decreases side effects. So yeah, there's a lot of really cool things about TMS.
Yeah, it's really amazing. And there's definitely been in the past, even like 10 years, an increased desire for alternatives to medication as a solution to mental health.
For sure.
And a lot of that definitely is holistic care, right? Our biggest referral out is always going to be therapy because you need both, right?
For sure.
Ideally. And so it's really amazing to see TMS come along because you have almost no side effects, especially when you can compare it to medication. And as you said, like your treatment duration versus your ROI, right? Your return on investment by time is so much bigger than what you could expect with most medications, especially when you've tried medications and you've had repeated failures. So how does a repeating magnetic pulse in the brain affect neurons, and how does that track into depression and autism treatment?
Well, again, it kind of gets back to the battery concept, right? So we can modulate neurons or nerves, and neurons is just a broader term. Our brain is essentially a bunch of wires. It's just a big mass of wires, right? But we call those wires neurons, right? So when we're trying to improve things in mental health, essentially we're trying to modulate brain activity. We're trying to modulate neuronal activity. Okay, so we can modulate activity in two main ways. We can modulate chemical activity, and we can modulate electrical activity. That's it. Those are the only two ways we can modulate brain activity. Chemical, electrical, that's it. So how we do that, though, can vary. So before I became more familiar with TMS, there was a study that was done by a group who, and I saw this with a psychoanalytic group, right? They're very into therapy, right? And psychoanalysis is still a thing. It's very expensive, but it can work, to your point, it can work amazing changes in people. And in this study, what they did is they actually did functional brain imaging, and they looked at functional brain activity when people are at the beginning of treatment, and then after, and these stages are a little bit harder. It's harder to do a double-blind placebo-controlled study when you're doing psychoanalysis, because psychoanalysis is typically 2 to 4 times a week for 3 to 7 years, plus or minus, right? So it can be a long, intensive treatment, hard to do placebo on that.
Right. You know when you're getting it.
Yeah, you know when you're getting the treatment.
Yeah. No sugar pills there.
Yeah. So, but they could still do a prospective study where they looked at the comparison of, does this person have any changes? And when the therapist and the patient, or the analyst and the patient, decided that, yeah, I'm in a good place now, I think I'm ready to finish therapy, they had them repeat their brain scan. And their functional activity in their left prefrontal cortex was increased. So that's pretty awesome. Now, I don't know how many people can do therapy 2 to 4 times a week for 7 years, or even 3 years. But there's something really valuable from that, which is we know that therapy actually changes brain functioning. That's cool. That's really cool to know that there's this. It was a small study. I think there were like 10 participants. It was not very big, but it was pretty consistent across the board that they saw this change happening. So we can modulate brain activity through medications, right? Chemically modulating. We can modulate through TMS. Now, what's interesting is there have been studies with all of those as well. There have been studies with medications where they've shown brain changes, like functional brain changes with medication. We also demonstrate it with TMS, that we see actually the brain's functioning differently with functional brain imaging. So we know that all three of those can actually affect change. I wanted to say something, though, to your point. And you said something about therapy. And I just wanted to put a plug. I will, in my experience, especially for depression, but I would also argue this. I don't have so much experience with autism spectrum. People who have done therapy are more likely to get a good response from TMS. So people who, and usually what I've seen is people know what they need to do and they just can't do it. And when TMS enables them to actually employ their coping mechanisms more effective, they're like, oh my gosh, they finally work now.
Right.
So it's that is actually really cool to see. But it's also, I feel like it's something really important for people to, I don't see TMS as this just fixes everything. All you have to do is
no
TMS
panaceas.
and then everything else, will be fine.
Right.
We have to do the work in the areas that we have deficits, right?
Mm-hmm.
But the same thing applies, I think, even with autism spectrum. People, and I keep on saying kids, but it can be adults as well when I'm referencing autism spectrum, but there are still coping mechanisms that people need to employ. The hope is, though, if you turn the gain down with autism spectrum, now people are able to employ their coping mechanisms more effectively, right? It's like, okay, I can go to Costco without my earbuds now, or at least I can look around with my noise cancellation headphones on. But I'm still okay. I can actually go to Costco now instead of I just didn't go there.
Right. Wow. Yeah, that's really great. I've talked to people about that a lot, and one of the things that I was taught repeatedly through my bachelor's and master's is the highest efficacy is when you have therapy and psychiatric treatment going together.
Sure.
It's way better than either of them alone.
Yep.
And I've talked to people about it, and I'm like, guys, it's like taking a half of your antibiotic pill, right? It's like if you are sick and you have an antibiotic and you take it half the time, the probability that you actually become resistant to the antibiotic is way higher than at least it needs to be, right? It's better to hit it all at once. When I think a really important question here is when does a patient know, or what are some good criteria for needing TMS for autism? And this kind of goes back, at least in part, to severity of symptoms. There's a NYU professor, Jonathan Haidt, who talks about the drift of the term of disorder. So if you look at like PTSD, right, there's been a big shift from it really only applies to shell shock soldiers to, well, it actually applies in these scenarios, and the number of things that would really qualify for a PTSD diagnosis have expanded over time. And so the criteria for a disorder, as I understand it, used to basically be, does it significantly impact life function, right? Can you live? Do you have a reasonable quality of life?
It should still be that.
Okay, good. I'm glad you said it. I wanted the doctor to say that.
Yes.
We started posting some like shorts talking about people who are like, oh well, if you have a lot of fun at parties or no fun at parties, you must have ADHD. We talked about like, well, one is it's not good if your criteria is no matter what you have ADHD, and two, there's things to discuss about like how much is this affecting you, right? What's your quality of life?
Right.
There is a typical range, right? And then there's things outside of that, and that's kind of what we're looking for. So who are the best candidates for TMS physiologically, but also socially and economically?
Yeah, I mean this. Okay, so let's first talk about the criteria. So, and we can talk about the other pieces in a second. But yeah, I mean I think it is where someone's functioning is, right? And so if someone's on the autism spectrum, and I mean, we call it autism spectrum disorder, right?
Mm-hmm.
So,
ASD, yep.
So in theory, autism spectrum is a little bit different than like major depressive disorder, right? Like if you have major depressive disorder, you might go into remission. So we have this caveat that you can be in remission from depression, or you can be in remission from bipolar disorder. Interestingly, though, we don't have remission for many diagnostic criteria. And that's actually, I think, just a failing of the
diagnostic
and
systems,
statistical manual, right? I mean, there's some things that it just, I feel like it doesn't account for. I think people can have generalized anxiety disorder, but have it well managed, but there's no criteria to say, oh, it's GAD in remission. It doesn't even make sense to me that we don't have that. So this is kind of a dilemma, though, too, right? With autism spectrum, there's no like, oh, well, it's in remission. But I think there could be less degree of symptoms. So yeah, how do you measure that? I mean, I think sometimes it can be someone is more activated from their baseline, and so maybe their baseline is more functional, and now they're more dysregulated or they're disrupted and they're not managing as well. So this could happen because of maybe something that is more traumatic, and I'm not necessarily saying PTSD traumatic, right? But something that just activates them. Maybe they, really like their teacher last year, and now they're in 5th grade, and now they have a teacher who's not quite as nurturing or understanding of autism spectrum, and going to school is just the worst thing ever. So is that something where, obviously I'm alluding to that's an environmental factor, but is this something where their ability to tolerate that environmental factor is not as good? And, perhaps they are not quite as much on their baseline. That might be a time to consider, TMS to help with the, essentially things that are related to overstimulation. So someone who's not as nurturing may create an environment where it is, they're going to be exposed to more stimulation. They have to change more. They're not able to finish their ritual before they move on, and so
the environment's exacerbating a deficit that was already there.
Right. And of course, as we get older, and this kind of the second thing, right, is that as people get older, it may unmask more of the dysfunction as their function should be increasing and they're not matching what they should be able to do for that age. So those are all things that might be considerations, right? So essentially, as time progresses and their function is decreasing or not matching what they should. Second is are they having a dysregulation beyond their baseline? I guess the third area to consider, though, is what if someone just has never functioned well at all and nothing has ever really worked for them? It still might be a time to consider, like, if they have these symptoms that are related, what I would call, to the overstimulation, TMS may be something worth trying. And especially, another thing is, like, have they failed medications? Have they failed to have an adequate response to therapy? Again, those would be another reason to consider TMS. So those are all things that might be helpful. It's always hard to broadly, do broad strokes, though, right? Because I think ultimately, I always defer to discuss it with your provider and make a joint decision with them. But certainly, that can be also challenging if your provider is not as familiar with TMS and how effective TMS can be with it. So those are, as far as an age, there's not really an age limitation. Now, I will be honest, we have focused more, and maybe this is, again, why I've said more kids become adults, right? So kids with autism become adults with autism. So can an adult do the autism spectrum treatment? For sure. I don't have as much experience with that, but the principle that I would apply is if an adult is having the same type of challenges then that would make sense. So all of the above criteria, right? So those seem to make sense. In terms of the cost, and I don't know if you want me to talk about cost here.
We can. I mean, I'm really proud. There's a lot of reasons I like working at Redemption. I've tried very hard to stay out of marketing and sales because I never thought it was an overly ethical profession. But here it's great because I just get to talk about honestly what we do and how it works, and I'm done for the day, right? I just have to explain. There's no sell needed, and so I get to sleep at night. And I really love this company, but our rates are drastically better than anyone else in the Valley. And on top of that, I don't think there's anyone else in the Valley offering a TMS protocol for autism.
Yeah.
So.
Yeah, and it's so. I mean, let's talk the numbers. I mean, typically a TMS treatment, like one treatment session, is $500, and so when you're looking at 30 treatments for depression, you're talking $15,000.
Yeah.
I actually heard about a group. I won't say where, that was charging $45,000 for a course of 30 treatments for depression. That's kind of crazy to me, but even $15,000 or $12,000, which is $12,000 is probably more the going rate, $400 per treatment. So that's hard. That's hard to afford, and most people can only afford TMS with insurance if insurance is paying for it. So we are able to offer because of things that we've done, and we just are so excited but convinced that this can help people, that we want to offer TMS at a rate that more people can access it. So I mean, like you said, I fear going too much into the sales aspect of this, but I think it's important to talk about, like, this is a practical part. We're talking about all these things that is so amazing. Okay, now nuts and bolts, who can get it? So the way we do the autism spectrum treatment, it's 10 treatments and it's $1,000 for the course of treatment. So it's usually over the course of 2 weeks. So we'll do 5 days a week for 2 weeks. So you're essentially looking at $100 a treatment. So it's like a 20-25% of typically what we see. But it's something that we just really feel strongly about, that we want people to be able to have access to a tool more easily than what they normally could have. So cool. So that's the economic aspect of it.
And then what you talked already about, one patient scenario, the mom and her child. What are the outcomes you're seeing with TMS, especially in relation to autism?
So I haven't seen as many patients on the autism spectrum. I've seen a handful, probably, and under 10. But typically what I'm seeing is that people are, again, better able to cope. They're not as easily overstimulated. When they're not as overstimulated, they're more interactive. They tend to be a little bit more able to engage in social situations. They're coming out of their room more. They're not stimming as much. They're not having the symptoms of being just overwhelmed as much. And so those are broadly the things that I've been seeing, that people just are functioning better. The other big question comes of, like, how long does it last? Now, interestingly, as Dr. Friday and I have talked about, just the theory of TMS and the inhibitory protocols, typically inhibitory protocols don't last as long as excitatory. So as a result, we've kind of postulated that people would get a response from maybe 3 to 6 months from doing the autism spectrum treatment. In practice, though, what I've seen, and some of the cases that I've seen, it's been actually longer. So like the one patient I was telling you about, she did well for about a year, and she's recently become a little bit more dysregulated. But at this point, her mom her mom describes her, so I don't know. I mean, this is not completely scientific, but her mom's pretty in tune with her kid, right? And she feels like there's something else going on right now. She doesn't think it's related as much to mood. So I don't even know if the benefit from TMS has even completely subsided after a year. So it's something that we've, again, anticipated that people may need treatments, every 3 to 6 months, but it seems like it's lasting longer. So, and this is something where we want to do more studies and look in literature more to see, like, is there something else? We're actually, and no promises here, but we're trying to work with a couple of groups that are doing research on autism spectrum and see if we can, answer some of these questions a little bit better, like, define a little bit better what are the outcomes, what do we expect to see, and 2, how long does it last, and 3, the third question is, how do we know if someone needs another treatment? Do we only measure that subjectively? Is it based purely on behaviors and the assessment of parents and the provider? It would be nice if we had a more of an objective measure, and this is where the functional imaging comes in. Is we're hoping that as we get more data and we treat more people and we look at pre-treatment, post-treatment, and we see improvements, that maybe we can do a 6-month scan at post-treatment and see how they compare to post or pre, immediate post and pre. And that can also give us more like objective measure of, is the functioning changing? Does it make sense right now or not? But those are all, some of this is still just postulates, hypotheses of like, okay, this makes sense of how we could measure that. We don't have quite the answers we'd like to have yet.
Right. Yeah. And it's hard because the needs now, right? And that's, I think, really the...
For sure.
Yeah. Mm-hmm. Cool. Anything else you'd like to say before we call it?
No, it's been a great conversation.
It's been a pleasure, sir. As always. Thank you very much.
All right. Thank you.
Hey guys, I hope you enjoyed that video. Redemption Psychiatry is a private practice located in the greater Phoenix area that focuses on mental health with advanced treatments for depression, anxiety, ADHD, OCD, and a whole lot of other mood disorders. If you or someone you know is struggling with mental health, please feel free to give us a call today or go to our website and set up for a new patient appointment. Thanks.